research focuses on traditional and non-traditional cardiovascular disease risk factors and chronic kidney disease, cognitive function and chronic kidney disease, and novel biomarkers of chronic kidney disease. He was a co-chair of the recent KDIGO Controversies Conference. He's funded by the NIDDK and the NIA and is a previous Garabed Eknoyan awardee of the National Kidney Foundation. He was on the steering committee for both the KDIGO Controversies Conference on heart failure and chronic kidney disease and blood pressure and chronic kidney disease, and is currently a steering committee member of the KDIGO blood pressure guideline update that will take place in 2019. He's going to provide insights from the recent Controversies Conference, and I'm going to turn it over to Dr. Sarnak in just a moment. I'd like to remind the audience that you have the opportunity to ask questions at any time during the presentation or after the presentation. And I will be monitoring those, and we will ask those questions back to Dr. Sarnak during the last 20 minutes of the webinar. Dr. Sarnak.
Thank you very much, Dr. Newby. What I'm going to be presenting today is just a general overview of this KDIGO Controversy Conference. It was a very, as I'll explain to you, it was a very big conference with a lot of data, and I think it's impossible to really go through all of it, but I'll try focus on some aspects that I think would be of interest to the audience. I'm presenting this on behalf of our entire steering committee and my co-chair, Tom Marwick, who's a cardiologist on the group. My conflicts, I'm on an executive steering committee of a company called Akebia. I don't believe it's necessarily relevant to this presentation. So I'm just going to tell you a little bit about the process that we undertook to arrive at some of the conclusions that I'm going to give to you. And I think, you know, we are currently writing this up, so I wouldn't say anything that I present today is exactly the way it will come out when we ultimately submit it for publication, but these are many of the themes that came up. So the goal of the conference was to present the current state of evidence regarding CAD and valvular disease and kidney disease, outline some controversies and unknown issues in this field, and also develop ideas for future research so we can move the field forward. We chose a steering committee, and I'll get to that in a couple of slides. We developed a scope of work that was then modified based on public commentary, and we invited approximately 70 participants from all around the world. Approximately 50% were cardiologists, 50% nephrologists, but those percentages are not exactly right. We had some pathologists, we had some ICU expertise, pharmacological expertise, etc. And then we held a 2.5-day meeting. This was held in Vienna earlier this year. There were 6 plenary talks. Basically were themes for each of the groups that I'll discuss in the next slide. We had 5 small groups, and they met about 3 times for 2 to 3 hours each time to discuss the questions posed. And they presented preliminary results to the entire group, you know, all 70 participants, received some feedback. They modified their presentations and then represented on the final morning. So this was our steering committee, and as I said, there were 5 small groups. The first group focused on epidemiology and screening. Each group had a co-chair that was either a cardiologist or a nephrologist, or in one of the groups could have also been a pathologist. So in the first group, Jonathan Craig was the nephrologist with Mark Hlatke as the cardiologist, and Kirsten Amann is a pathologist, and Ulf Landmeister was the cardiologists involved in the second group, which pathology and pathophysiology. Diagnosis and treatment were David Chariton and Sripal Bangalore, and valvular disease, Alan Jardin and Jose Cavalcante. And then in transplant was John Gill and our moderator, Kristen Newby. We're going to primarily focus on the first three groups just because of time limitations. So let's just talk about each of the breakout groups and what the goals were and what were the populations they were studying. So breakout group 1 focused on all stages of CKD, not transplant. And similarly, this was for breakout group 2, 3, and 4. Group 5 focused on transplant itself. The breakout group 1, were particularly interested in epidemiology, screening of CAD and of valvular disease. As I said, I'm not focusing on valvular disease itself in this talk. Group 2 was pathology and pathophysiology of CAD and valvular disease. Group 3 was diagnosis and treatment of prevalent CAD. Group 4 was treatment of prevalent diagnosis and treatment of prevalent valvular disease, and the last group focused on transplant recipients. So as you can see, it's a very broad topic, and I'm sure people will have many questions that I don't focus on here, and you're welcome to bring those up after I finish the presentation. So let's talk initially about group 1, and I'm going to focus on 4 general features in group 1. And the first thing was just general epidemiology of coronary disease in patients with kidney disease, or of cardiovascular disease on a more broad sense in those with kidney disease. A second topic was presentation with CAD. How is this different in those who have CKD? Do they present in a different way? We discussed some on risk prediction of CAD. How good are risk equations to estimate incidence of CKD in those with CKD and end-stage renal disease? And I'll provide just one slide on screening. As I said, what I'm doing is, very broad strokes discussion of these issues. So this is just talking about prevalence of cardiovascular disease in ESRD patients from the USRDS. And I can give you, other slides of patients with CKD, that look at coronary disease or valvular disease in patients with ESRD or CKD. And essentially, as I'm sure everyone knows, just a high prevalence of coronary disease, history of AMI or acute myocardial infarction in hemodialysis, peritoneal dialysis patients. And even if I showed you CKD patients, also, an increase in all of these things, with the increase starting usually when the GFR is about 60, but, linearly increasing as you reach end-stage renal disease. So high prevalence. I'm not going to show you the incidence, but there's also a high incidence in dialysis patients. If you look at what happens to dialysis patients, this was data that we undertook already many years ago, and it's looking at all types of cardiovascular mortality in dialysis patients. And essentially, it was comparing on the top part of the curve. I don't know if you can see my arrow. I'm not sure about that, but the top part of the curve is all dialysis patients. The entire bottom part of the curve is all non-dialysis patients, and this is comparing cardiovascular mortality in all dialysis patients versus everyone in the general population. And what you can see in the younger age, this is a log scale on the y-axis. You are approximately 500-fold more likely to die from cardiovascular disease if you're a dialysis patient compared to someone in the general population. And it doesn't make a difference if you're black, white, male, or female. And if you compare a dialysis patient at a young age, at the age of 25 to 34, and you extrapolate a line all the way to the general population, that's almost the equivalent of an 85-year-old in the general population. So there's just an extremely high case fatality rate of all cardiovascular disease, as well as a patient who has an MI, just high case fatality after that MI. If you look at the earlier stages of CKD, this was old data of ours from the ARIC study, and what you can see as the GFR gets below somewhere between 60 and 90, there's just an exponential increase in the risk of developing, in this case it was atherosclerotic cardiovascular disease, but it's very similar with coronary artery disease itself. Obviously much stronger relationships in the orange part of the curve when it's unadjusted, but all of these relationships remain significant in multivariable adjusted analysis. So CKD itself, well accepted, high risk group for all cardiovascular outcomes. If you consider the other component of CKD separate from GFR, albuminuria, we see very similar findings, and I'm not going to reproduce that. So these were two themes that came out of future research in the epidemiology. One is the need for population-based cohorts of individuals with kidney disease at late stages. So we have a lot of data in the dialysis population. We're now starting big studies in late stages of CKD. Examples would be the CRIC study or the German CKD study. I'm sure there are many others all around the world. But as we know, some of the relationships change as you move through the stages of CKD, and there's lots for us to learn as we evolve through the stages. Also, longitudinal studies in the earlier stages, as you're transitioning into CKD, as you initially obtaining GFRs less than 60, and examples would be, from Kaiser and other general population studies. Another theme that came up was the need for standardization of clinical endpoints, and particularly as it related to composite endpoints and differentiation among endpoints that may be due to different mechanisms. And I'll come back to this a little bit later. When we think about CKD, the type of kidney disease, the type of cardiovascular disease in CKD, we've got to be thinking about atherosclerotic, heart failure, arrhythmic or arrhythmogenic, and often this all gets lumped into these outcomes, but the mechanisms for each may be separate, different, and we need to come up with consistent definitions for patients with kidney disease that are susceptible to several of these cardiovascular outcomes. So I'll now move to the second part of this, which is the presentation with CAD and CKD, and I can discuss some of the studies if we have time or if people have specific questions. But as we go through the talk, I'm going to be giving slides that say what is known, what is unknown, what are things that we may want to be studying in the future. So, and things that I've said are known for the most part have been reproduced in several studies. So patients with CKD, and this is primarily as your GFR gets below 45, they're actually more likely to present with AMI than stable angina. And this is true, as you go below GFR of 45. Patients with CKD and end-stage kidney disease who present with AMI are much more likely to have atypical presentation. So they often don't have chest pain. They may just have shortness of breath. They may just have nausea. And they also frequently have non-diagnostic EKGs. And this is because they have a tremendous prevalence of LVH by the time they start dialysis, and that prevalence of LVH increases as your GFR declines. With advancing CKD, there's a higher likelihood that the patients start presenting with non-ST elevation MI versus ST elevation MI. So this is not saying that the ST elevation MI isn't an absolute increase as your GFR declines, but just the proportions kind of change as your GFR decline. And I'll show you a slide after this that there are clinical transitions that occur between advanced CKD and end-stage kidney disease where, heart failure and non-atherosclerotic events become more frequent compared to these atherosclerotic events. This is one slide from the USRDS, and it's actually looking at ST elevation MI and non-ST elevation MI by different time periods. And you can see the non-ST elevation MI are increasing over time. I think part of this is due to how these non-ST elevation MIs are defined. You know, we're measuring troponins more frequently. But either way, in dialysis, these non-ST elevation MIs are more common compared to the ST elevation MI in comparison with the general population. This is a slide from a review by Wanner et al. And what you can see as you move along the green line, which is stages of CKD, in the bottom part of the figure, you know, as your GFR declines, as I said to you, there's a higher case fatality after you have the event. So after you have that event, the chances of you dying after that, you know, increase as your GFR declines. But also as your GFR declines, you have an increase in all of these atherosclerotic events. But as you decline more, you start having a lot of these also non-atherosclerotic CVD. Some of these are surrogates like LVH and things like that, and valve calcification. But others include, you know, sudden cardiac death. I think you could argue heart failure could be included in this figure. Heart failure becomes very highly prevalent as your GFR declines and is associated with bad outcomes. So what are ideas? What are some of the ideas for future research as we went through this? The pathophysiology of differential presentation versus preserved kidney function. I don't think we know the reasons for this. Is it related to autonomic dysfunction? Is it related to type of plaques? I'll go into this in a little bit more detail. Small vessel disease in the setting of LVH, exactly why that would make the presentation different is less clear. You know, there was some interest in intradialytic hypotension. Is this a manifestation of potentially CAD itself or abnormalities in the ventricle? And future directions, may include some studies of pathophysiology of these differential symptoms, how accurate EKG changes are for diagnosis of acute MI, and, optimal pathophysiology and optimal workup for intradialytic hypotension. If we then move into the next topic, which is risk equations, this is a study from the CKD Prognosis Consortium. And I think, and they've, meta-analyzed multiple cohorts that have submitted data to the group. And so it's a big group of patients with CKD. And as we all know, as your AC, on the left-hand side of the figure, as your GFR declines, higher risk of cardiovascular disease and coronary disease. And as your ACR increases, higher risk of cardiovascular disease and coronary artery disease. But what they were particularly interested in is how much do these kidney components of CKD add to risk? In other words, AUCs and C statistics. And what you can see is that when you look at the cohorts that had albumin to creatinine ratio, and if we particularly focus on coronary heart disease outcomes, eGFR adds by increasing the C statistic, as does proteinuria as well as their combination. These are not big numbers, but when you start off with a C statistic of 0.7, it's very hard to improve this. And if this is just an interesting point, if you say took out diabetes from the beginning, the ACR will have more of an effect than the diabetes. It's just that we have these risk equations that were developed in the past, and we're trying to add to that. But if you look at the relative importance of, say, ACR compared to diabetes, it will compare favorably and similarly with GFR. This is a similar kind of figure looking at how important CKD is compared to diabetes and smoking, which are very strong risk factors. And this is looking at the combined ARIC and CHS populations. It's an older study of ours. And you can see in certain populations, like in Black men or in Black women, CKD is a much stronger risk factor for developing coronary disease than is diabetes. Diabetes in these bars, the CKD being the black bars, and also much stronger than smoking. And this is true even if you create the best models to predict coronary disease, using adjusted Framingham risk equations. However, if you look at a CKD cohort, so in other words, people only with CKD, and you look at how good are like the Framingham risk equation to predict outcomes. I don't show the data over here, but if you take all the traditional Framingham risk factors and try and predict coronary outcomes, C statistics are, between 0.6 and 0.7, which are not great. So the Framingham risk equation has pretty poor discrimination in kidney disease. And this is just a slide of calibration. So it's looking at observed events versus predicted events, and you can do it calibrated or non-calibrated. And what you can see is that in CKD, we don't calibrate that well. Part of the reason is the events are much more frequent, so you can recalibrate and get a little bit better numbers in the dark brown compared to the blue. But still issues with calibration in CKD cohorts. And we haven't developed, prediction equations in CKD that will be applicable. What needs to happen is, the coefficient for blood pressure, for diabetes, all of these things will potentially change. There may be some other variables that would be included in the equations, including obviously GFR and ACR at the least. If we think about prediction equations in dialysis, I think we're all aware that many of the traditional risk factors just act in the opposite way. So this is like cholesterol. And those patients with lower cholesterol have the highest mortality on the left-hand side of the figure. And if you look at blood pressure itself, it's the same thing. So lower blood pressure on the left-hand side of the figure in dialysis patients is the risk factor, not the high blood pressure. So clearly in dialysis patients, things like the Framingham risk equation are going to be terrible. And if we want to try and predict coronary events, we need alternative equations. So future research in this area, so we need to adapt widely accepted atherosclerotic risk predictors to the CKD population. And things that we may want to do is add CKD-specific terms, learning from other cohorts. We may assess further need for refitting the model, so the coefficients may be different based on each of the traditional risk factors. And we may want to add novel risk factors. There may be some things that are particularly important in CKD, whether it be markers of calcium phosphorus metabolism, BNP, troponins, etc. And then in the end-stage kidney disease, we have to, start from the beginning. And whenever we think about outcomes and developing prediction equations, we need to think, can we use composites, especially when there's potential different mechanisms for each of the cardiovascular outcomes in dialysis, or do we need specific quick equations for, say, heart failure, sudden cardiac death, MI, etc.? And we discussed some about transplant in the last, but I'm not going to focus on that. As I said, I've got one slide on CAD screening in CKD. I think the important thing is CAD is common and serious in asymptomatic CKD patients. I've emphasized that. But screening tests for asymptomatic CAD appear to be less discriminating and effective in the CKD or the end-stage kidney disease population. So if we screen in the same way that have been recommended in the general population, we may be even less accurate in the CKD population. And there's no evidence that coronary revascularization is effective in any asymptomatic population, let alone more effective. So In other words, high-risk diabetics, there's no evidence that we should be screening in that population. So I think based on our review of this, screening for CAD is not recommended either in the general population or in other high-risk populations or in CKD. I mean, it may be correct, but we don't have data to suggest that. I'm going to go through pathology relatively briefly, but I'll just focus on a few things that we were interested in. So we were interested in pathology of CAD, comparisons with the general population, atherosclerosis, arteriosclerosis, calcification. We talked some on plaque vulnerability. So here's one slide just from a manuscript about 9 years ago, just looking at coronary artery intimal plaque calcification. And at the top of the slide is the different stages of CKD. And what you can see is that calcification in the intima of the coronary disease, of the coronary artery, this is actually in autopsies, is increased as your kidney function declines. So I think we're all aware that there's increased calcification of these blood vessels as your kidney function declines. When we're learning a lot about calcification in the general population, and this was a review from Jack this year, and I'm not going to go through the whole slide, but there's a lot of research going on in understanding the different types of calcification. The histological calcification, where you have no calcification, to sheets and nodular calcification, versus how we image for calcification, whether it be your CT or your ultrasound or just by radiograph or autopsy. And, there's a general feeling that as you get more calcified, maybe this is more consistent with more stable multi-vessel disease, and perhaps less likely for acute rupture, and maybe the calcification may even have some stabilization effects. And in general, those with diffuse calcification tend to be older. So the question is exactly, where does kidney disease fit into all of this? In general, we think for the most part it's going to be on the right-hand side of this figure. Frequently, at least in dialysis, we'll have multi-vessel disease. The patients will be older. They've got extensive calcification. But this, hasn't been studied in as much detail in CKD. Another area related to the pathology that's becoming more interesting recently, and this was just editorial by Libby in the European Heart Journal last year, talking about different types of acute thrombus, and white thrombus versus red thrombus. And the reason why these are maybe different, the red thrombus is your classic, occlusive thrombus, probably more likely with the ST elevation MI, although I don't think we are 100% sure about this, versus the white thrombus, which is more just due to an erosion rather than a plaque rupture. And the question is, where does kidney disease fit into these two categories? And I don't think we know that. And so these are obviously areas of interest and areas for future research. So some of the research questions related to pathology. This one was interesting. Is there increased calcification of the media in the coronaries in CKD? Or is all the calcification that we see on that EBCT actually intimal calcification of the meaning plaque, and not just medial calcification? And this was kind of a little bit of a controversial area in the literature, because we don't have that much pathology. We talked about how to target inflammation and senescence, which appear to be primary drivers for this calcification. We talked about plaque erosion or rupture in the CKD spectrum. How do these relate to type 1 versus type 2 MI? Is the type of dialysis you do relevant to being at risk for these things and different forms of pathology? How does transplantation affect these issues? And then sudden death, which we know is a big issue, at least in dialysis patients. Is this a manifestation of CAD, or is this primarily an arrhythmic event versus an ischemic event? So now I'm going to, in the last 10 or so, 15 minutes, I'm going to primarily focus on diagnosis and treatment questions, and I'll focus on two areas that we discussed. Like I said, these are two that I've chosen. One was diagnosis of coronary disease, and this includes functional testing and troponins. And the second was treatment of CAD and, asymptomatic versus symptomatic patients, optimal medical therapy versus not. What type of revascularization should we be using in our CKD patients? So it turns out we actually have quite a bit of data on testing in dialysis patients for patients who are transplant candidates. It was kind of clear that in those patients who are asymptomatic and are not transplant candidates, they don't get stress tests, and we don't have as much data in them. But the patients who are potential transplant candidates, we have a lot of types of testing. And I think important to acknowledge right from the outset that, we have different types of testing, whether it be myocardial perfusion imaging versus assessment of the structure of the arteries, like coronary CTA or something like that. And when we think about stress testing, it's always useful to or the imaging, it's always useful to think, why are we doing them? Are we actually trying to determine what the coronaries look like under angiogram, which is presumably the gold standard, or are we trying to assess the prognosis after the transplant? And tests may have different, there may be one test like a CTA, presumably will be good at telling us the structure of that coronary artery, but maybe the myocardial perfusion imaging or the stress echo will be better for prognosis. So I think you always got to think of the actual goals of the test that you're doing. And this is just one particular study that shows you sensitivities and specificities of all of these tests for a gold standard angiography, so not for prognosis. And when you look at types of stress imaging, you can do dobutamine stress echocardiography versus myocardial perfusion scintigraphy in kidney transplant recipients. Some studies suggest that the stress echo may be a little bit better, but this is not, I wouldn't say this is consistent throughout the literature. And I think in general, we've recommended do the studies that your particular center is best at. And, I don't think it's although some may suggest, stress echo is done better in some studies, I don't think that's universal. So let's talk about stress testing. When we review the literature, what is known? So I think this is pretty clear. There's a reduced accuracy of stress testing modalities in CKD, end-stage kidney disease, versus those without. So this is the gold standard being the anatomy or the angiography, much less accuracy in CKD. There's both false positive and false negative results. Tests do have prognostic value. So if you have a stress test and it's abnormal, that's bad. Or if you have a stress test and you've got a fixed defect or something, that's associated with bad prognosis. So these tests do have prognosis, but they're not as accurate as they are in the general population. Important to recognize, if you've got a normal test in CKD, you're still much higher risk than the general population. So if you have a completely normal stress test before your transplant, it's not completely uncommon that that person will still have an event afterwards. So they're just much higher risk patients, partly because the tests are not optimal. reduced exercise capacity, obviously, in CKD, and you've got a lot of these baseline EKG abnormalities. So we usually recommend not only stress EKG, but also imaging as well, because the EKGs are frequently abnormal to start. So what's not known? Can ancillary markers improve stress test accuracy, e.g. a troponin or something? Is exercise capacity prognostically important, right? This is always a question that's asked in the general population. How many METs do you reach, etc. In CKD, this is not studied as well. How does test purpose, as I've discussed with you, prognostication versus identification of, structural CAD impact the choice of testing? How should test results be used? Again, for think of what you looking for and what you want, how you want to use it. How does the pre-test probability impact test choice? And as I said, there's all these stress tests that we have. The literature is all in pre-transplant. What about a dialysis patient who's not pre-transplant? Is it the same, or is that a sicker group? And the accuracy may be even less. Future directions: utility of PET and quantitative blood flow imaging. Flow reserve and things like that, role of non-gadolinium stress MRI. These are things that are being developed in the general population, not studied that much in CKD. And as I mentioned, accuracy in non-pre-transplant candidates. Use of troponins in the diagnosis of CKD, so elevation at baseline. Is the frequent elevation, so this is accepted. High prevalence of abnormalities, and those elevations provide prognostic information. Multiple studies show that if you've got ACS or you don't have ACS, the higher it is, the worse you do. Higher levels are associated with obstructive CAD, but they also reflect LV mass and volume status. And I think this is quite well accepted that the way we diagnose MIs in CKD and dialysis, particularly our dialysis patients, are changes. So you've got to look at the dynamic changes in someone who suspected ACS. What is not known: should baseline elevation trigger subsequent testing? There's no studies that have assessed that. And what is the predictive value of an elevated high sensitivity troponin to predict the actual structural abnormality? We discussed, should you actually do an annual troponin so you have that baseline? And will this affect how we treat the patient? And when would we do this baseline troponin test? And how do we rule out the MI very quickly in a dialysis patient? What thresholds do we need, and what kind of delta change will be reassuring that this patient is really not having ACS? So in the last part of the talk, I'm just going to focus on some treatment-related aspects. And so when we talk about treatment and to prevent coronary disease and for treatment of coronary disease, I think from the outset, we've got to recognize that our patients are excluded from trials. So this is the most recent review that I've seen on this, published in JAMA Internal Medicine, or the Archives of Internal Medicine. And it basically just tells us that, patients with CKD are excluded from a lot of these studies. So if you take a look at calcium channel anticoagulant-related studies, third from the bottom, if you've got CKD, 90% of the time you're excluded from the trial. So this is our biggest limitation. The people who design the trials and the meds know that people with CKD are at highest risk. So when you're coming up with a new med, you don't want bad outcomes. So this is what we have to deal with and try and make it a requirement that patients with CKD are included in these trials. This is just more data on exclusion and reporting of CKD. So if you look over here, CKD is frequently not even reported, like in a table 1 in some of these trials. So other people are not as interested in it as we are. And then if you've got CKD by whatever definition over here, half of the patients are just excluded from the outset. So just going to show one slide on dyslipidemia. I think you've all seen this. This is one treatment in CKD where we have in patients we have a treatment to prevent atherosclerotic outcomes. This is ezetimibe and simvastatin, and in the SHARP trial and reduced atherosclerotic cardiovascular outcomes. There's some debate about the interaction in the trial and things like that, but in general, our recommendations, and I can certainly discuss them later, are that statins are our lipid agent of choice. We should treat all patients with CKD 3 to 5 who are not on dialysis, who are over 50 years of age with a statin. And I can discuss in more detail if people are interested how these recommendations came up. Where there's no target, but there's no evidence to initiate treatment in those on dialysis. And this is based on other studies, including 4D and Aurora, etc. Regarding revascularization, what's known in non-CKD? And this is a dense slide, but it's basically general population recommendations. If you've got stable CAD and you've got optimal medical therapy but persistent angina, you may want to revascularize. And then obviously there's certain populations that may do better if you revascularize. If you've got unstable angina or ACS or MIs, etc., generally early invasive, if you've got refractory angina, instability, etc., some recommendations even to not include patients with kidney disease in some of these early revascularization. So this is general population, just general guidelines. If we think about, and I'm just going to show a few slides of this, of treatment of CAD in CKD and end-stage kidney disease, and this is looking at observational data, right? So the thing over here is that looking at 14,000 people total who get different procedures for their coronary disease. What you can see is in long-term follow-up, those who get the CABG tend to live the longest. Most of these studies tend to show they have the highest risk of early events. And this is another study that compared long-term survival of CABG versus PCI among dialysis patients, early events in the dialysis patients, but then tend to be a better survival in the long term. So what is known about this is that non-dialysis CKD patients, they have short-term higher risk of death with CABG versus PCI. Long-term, the CKD patients in general, they do about the same from the death standpoint, but they have higher MIs and repeat revascularization if you have a PCI versus a CABG. In dialysis patients, also adverse outcomes short-term with CABG, death or stroke. In the long term, they do better. The problem with all of these data is they're all non-randomized, and they're all subject to selection bias. So, depending how much you believe you can adjust for these things, you come to your conclusions. But I think there's a lot of indication bias, and there's some patients, the surgeon will just say, I'm not doing a bypass, and that person will be forced to get a PCI, and that will be the sickest patient that you can't adjust for. Revascularization for stable CAD. So what is optimal medical therapy? What is the benefit of revascularization to improve prognosis? How you deal with this upfront risk and other competing risks. What's the value of early invasive therapy? If you do the PCI versus the CABG in the CKD patients, their kidneys may shut down more likely in one versus the other. And then other big outcome is mortality and CV. And then for left main disease, PCI versus CABG, how does this affect prognosis, risk of AKI if you're a CKD patient? The last issue I'm going to just quickly focus on that was kind of controversial is obviously there's a literature coming out that using radial access for an additional arterial vessel for CABG, and this New England Journal paper that suggests that those with the radial artery had reduced amount of the composite outcome, death, myocardial infarction, if you use the radial artery versus the saphenous vein. Turns out in the renal insufficiency group, those hazard ratios were actually opposite, interestingly enough. And then, people are also using radial versus femoral access for cardiac catheterization. And this was a big study published in Lancet in 2015. And those patients who you use the radial access, do better and have less all-cause mortality, MI, and stroke. Now, the reason why this is relevant to CKD is, as you know, we all think our dialysis access is extremely important. And how does, if you use the radial access for the bypass, you're clearly not going to be able to use it for a fistula. And if you use it for a catheterization, or you may be losing a potential future access for AVF or something like that. So this is where we come into this literature, and at what stage of kidney disease may you be reluctant to use a radial access for catheterization. So I've gone a couple of minutes over. This is just one trial, so we are doing some trials in CKD, and this is called from the ischemia trial, which is a big trial of optimal medical therapy. There's a CKD component of the 750 patients. Ischemia, GFR. These patients have GFR less than 30 or on dialysis, and we're going to evaluate. I shouldn't say we. The investigators are going to evaluate is optimal therapy as good as cath and optimal revascularization. Future directions: CKD-specific trials of optimal medical therapy, CKD-specific trials of revascularization. Get the patient involved in these management strategies. Should we be using multi-arterial grafts, as I hinted at, and CKD-specific data on use of radial access for PCI. So I wanted to thank everyone. I wanted to thank the KDIGO leadership and the organizers, all of those in orange on this slide who were very helpful in organizing the conference and enabling it to happen. Participants of the conference, steering committee members, including Dr. Newby, and sponsors. Thank you very much.
So thank you, Mark. That was a terrific overview. Let me remind the audience that if you navigate to your control panel and select questions, you can type in questions for Dr. Sarnak to address. And I'll be monitoring those. I'm going to start with one question, Mark, since we've got a little bit of time. And since the title of our session was coronary disease and valvular disease, I wonder if I could impose on you to just say one or two things about valvular disease in CKD patients. And in particular, I think thinking about aortic disease.
Yeah, so I think... Right. So we discussed valvular disease in several components in this conference. There was a whole valvular section, as we said, for diagnosis and treatment, but then we discussed it in the pathology as well and in the epidemiology. So there's a very high prevalence of abnormalities in the valve as the kidney function declines. And this starts off with calcification, mitral valve, and the aortic valve. And I think what we see is a lot more of aortic stenosis that progresses much quicker, particularly in our dialysis patients, and maybe partly due to abnormalities in calcium and phosphorus metabolism. So clinically, I've occasionally seen these patients have, normal echoes, and a year or two later, with poor phosphorus control, high PTH, and the next thing they've got severe aortic stenosis and calcified valves, and very hard to treat. And there's also a lot of abnormalities on the mitral valve, mitral regurgitation. So all of the high prevalence of all of these type of things. The one thing, interesting topic we addressed in the valvular group, which is obviously, which of these patients should we be considering alternative type of valve replacements, open valve replacements, TAVR or TAVI, and how do patients with kidney disease generally do when we do these novel, they're not really novel anymore, but are they appropriate and for doing these kind of procedures in our old dialysis patients?
And a question came in related to that, and I think you've partially addressed it, but let me kind of take this a little bit further. The question reads: what is your take on valve replacement in patients on dialysis? We struggle to get a surgeon agreeable to take dialysis patients to the operating room because of presumed poor outcomes.
Yeah, I mean, I think this is probably a universal issue. What's best for the patient? How is the surgeon being evaluated? Are they willing to take risks with certain number of patients? And all of these things, unfortunately, come into consideration. I think clearly dialysis patients, healthy dialysis patients, should get valve replacement. So, a young dialysis patient, we have many of them that go through these surgeries in the past, with open procedures and did fine. They're clearly at higher risk than someone in the general population, but they do, if they get through the surgery, if you're talking 5% mortality or 10% mortality, they do still got a much better chance of surviving with the new valve. We are, at least in my own medical center, some of the more frail patients, and I think we're probably moving to even some of the less frail dialysis patients are frequently being considered, at least for the aortic valve, for the TAVR or the TAVI. And whether that's right or wrong, and I don't think we have the great data. We don't have the randomized trials in dialysis patients. There's no question that the dialysis patient with TAVI does worse than the non-dialysis patient with the TAVI. So I think this is a challenging aspect in all programs. And sometimes I think one thing that came through very clearly was that there needed to be patient-centric approaches, and sometimes saying to the patient, if you're 90 years old on dialysis, maybe it's not the right thing to go through any type of valve replacement if you're frail and in a nursing home or something like that.
Yeah,
it's not going to change.
Yeah, tough area for sure.
Yeah. Yeah.
Let me direct another question going back to coronary disease. The question is, do you know of any plan to study differences in coronary disease between hemodialysis and peritoneal dialysis patients based on their exposure to calcium, elevated or constant calcium levels?
Yeah, that's a very good question. And I don't know detailed comparisons between the two of them. There's the high prevalence in both PD and HD of all of these things. There's always some selection biases as to who ends up on PD versus who ends up on HD. In the US, it's often the younger person who, in the US, it's only 5 or 10% of people who are on PD, and that's often either the young person who can do it at home or the person who's failed hemodialysis. So they tend to be different groups that end up. And obviously, all of these cardiovascular outcomes happen the same. Is the mechanism going to be a little different, right? Could you say that in hemodialysis you have stunning and intradialytic hypotension, and that causes certain type of abnormalities in the ventricle, maybe in the coronaries, whereas the PD patient may be exposed to more metabolic abnormalities, with a peritoneal dialysate. So it's an interesting question, and I don't think we know we know there's differences in cholesterol, the types of cholesterol in the two different groups, but I don't know of great data comparing the types of coronary disease and calcification in the two groups. There may be data on that. I just may not be aware of it.
Great. And then this is an interesting, I think, an important question and interesting question. Using high-sensitivity troponin to diagnose, it says coronary disease. I'll interject acute coronary syndrome or MI. Is there any cutoff point for confirming the diagnosis in dialysis patients, or serial testing, how to confirm it?
Yeah, a completely valid question, and different people are. Part of the problem is they're getting checked for any reason. When, at least in the US, sometimes you'll come in with a headache and you'll have the troponin, unfortunately, and then you're like, it's abnormal. What do I do with it? Was it done? So I think the first thing is to try and do it under the appropriate setting. This is why we mentioned, should there be like a baseline, right? And if you've got a baseline and its baseline is elevated and it's not changed, that's reassuring. If you don't have a baseline and
the way we diagnose it is we just check it again, 6 or 8 hours later and see which way it's going. And if it's increasing, then we usually gonna give it the diagnosis of a non-ST elevation MI. But what kind of increase is relevant? I don't think there are any definitive standards on this, and all of us are doing this a little bit differently. But it's obviously an active area of research and an active area where we can, I think, improve the care of the patients. Like I said, this is clinical practice that we're dealing with every day, that troponins are abnormal. And, frequently we'll just say, don't worry about that, focus on the pneumonia or something like that. Don't go look further. But whether that's right, I don't know. Clearly, when they elevated, that patient does worse in some way, whether it's ACS and whether there's any reason to do a stress test or to intervene, obviously depends on the other clinical characteristics that the patient has at that time.
Yeah, I think you're exactly right, and I think the point you made are tests in the right setting. Elevation itself is prognostically not good, and if there's a dynamic change, and most of the algorithms for high sensitivity troponin that are available that have been widely used in Europe for a while will pick up the same kind of delta in chronic kidney disease and or end-stage kidney disease patients. So I think as far as we know now, but a lot more research needed. And then I'm going to take the liberty of one final question, because I think this is interesting in a bit of a different perspective. Are you aware of any evidence that vegan diet adherence is an intervention or effective intervention for CKD patients, in that it could slow progression of coronary disease or kidney disease?
That's a very interesting question, and I think probably there's probably some data to suggest this may be helpful. I think from the kidney disease progression standpoint, we don't have the randomized trials. We have the randomized trials on different protein diets, and I think they're not definitive. I think what we know is that red meat itself is is probably not good for progression. So high red meat protein is not promotes progression. Other components of the vegetarian diet, may be helpful. There's some data that high potassium diet, obviously low sodium diet, may be good for kidney disease progression and may be good for cardiovascular disease. But I don't think we've got the trials on these type of things, at least for the vegetarian diet itself. The diets have been more related to, DASH diet versus protein itself.
Great. And then one last question, and this gets back to your comments about statin use. We have a couple of questions on that, but I picked this question to kind of get the theme out. What is your input regarding the recent observational studies regarding statin use in dialysis patients and increased risk for coronary disease by worsening calcifications and higher coronary artery calcium scores?
Yeah, okay. So coming back to those the guidelines in dialysis patients, I don't think the guidelines generally recommend if you don't have coronary disease, don't start it in dialysis patients, and that's most of the 4D study. Only 20% had coronary disease. In the Aurora, I can't remember the percentage, but I think it was about 20%. So there's no evidence that it helps. In the 4D study, in those who got the statins, the 4D was randomized 20 milligram of atorvastatin versus placebo. The hazard ratio for the coronary events was not significant, but was in the right direction. So I personally think the statin may have some benefit if you had a big enough trial, but our patients are dying from many other things. They're competing risks, like I said, of heart failure, arrhythmias, where the statins don't have any benefits. And then if you've got like a coronary event, someone has an MI, I think we all deal with this, the patient will immediately come out of the hospital on a high dose of a statin that was given by the cardiologist. I don't think we know if that has a benefit, even in the person who's had a recent event. I think most of us will continue it. So I don't think